Well, you've introduced us now to the concept of antithrombotics, to what to do at what stage of disease and duration. Let's drill down into that a little bit. So you talked about ACS, and I think, as you said, most people would say the anchor right now and the guidelines based on the trials of data is a year of dual antiplatelet therapy in someone that's coming with ACS, assuming that they're not bleeding or other bad stuff isn't happening.
And that may change over time, but right now I think it's still...
Yeah, it may change, but certainly from a stent perspective, the durations don't need to be a year necessarily. But from the plaque rupture thrombosis ACS perspective, I think that still remains the anchor. But getting past that year, what would one do in the patient with a history of prior ACS? Options being de-escalate to aspirin monotherapy or clopidogrel or ticagrelor monotherapy, for example, or to continue whatever DAPT regimen they were on, or potentially to even throw an anticoagulant in the mix. So what would be the approach?
Yeah, so that's a great question. You know, currently after 1 year now, quote unquote, they have stabilized and we're treating the continued risk. You know, they're with Pegasus TIMI 54. That was a good study on ticagrelor, 60 milligrams twice a day with aspirin, and up to 3 years out, they had with certain high-risk futures, they had benefit on ischemic reduction, not necessarily a net clinical benefit on survival, but there was ischemic reduction. As an interventionalist, how I look at this is I break it down into what is the angiographic factors in there and what are the clinical factors. And the DAPT score does something of that nature. So what I mean by this is if I'm dealing with small arteries and I'm putting lots of stents, that is a higher risk angiographic patient. Now you throw in that they're diabetic and history of smoker, definitely the risk keeps going up higher for ischemic events, and now I want to be probably more cautious with what type of antithrombotic regimen I'm going to continuously place them on. Versus now, let's say we did an ACS patient and it was a proximal RCA, it was a large stent I was able to place, post-dilated appropriately, OCT shows excellent expansion. Those are patients now that I feel much more comfortable de-escalating and that their risk factors are angiographically not great, and I mean, not high, and then clinically, we're not having as many risk factors. So they're patients, I believe, that their ischemic burden is lower. And so when we're talking about trials and DAPT duration, I think what's been lost is it's not just one variable or three variables. It's literally the components of what the anatomy is looking like and what we have to do to treat it, and then what the patient clinical factors.
So let me ask you, everything you said makes a lot of sense, but there's some complexity to it. You mentioned OCT, good result. And that's all appropriate optical coherence tomography. It's a way of imaging from the inside that interventional cardiologists use. But that's a lot of information. If that's in your report, a primary care physician may not fully follow exactly what you were referring to with post-dilation and everything. So who should make that decision at a year then in terms of what to do with that patient? Should that be the primary care physician, or should they call you, or should you be seeing that patient? What is the way that you would recommend handling that?
I typically recommend, if you're the person to put that stent or treat that patient, you should continue treating that patient and make that clinical decision. I think for a primary care physician who is not involved in that procedure, it's hard for them to know what to do, afterwards. And what I mean by all these ways of imaging and testing is so that when I'm at the very end making my impression, I'm having both clinical and procedural aspects to help me conclude on why I'm going to utilize a regimen.
Right, and the other thing you have to factor in is what happened in that year in terms of recurrent events or bleeding, which might alter the strategy. And bleeding, I mean, you've thought a lot about bleeding. You've probably caused some bleeding along the way too.
Absolutely.
Is bleeding important? Obviously it is.
It's really,
but how does that factor in?
I just want to challenge for a moment.
Oh, please challenge Bob. He needs to be challenged.
Yes, yes, indeed. Because I think in theory, you're absolutely right. You're the operator. You know what the anatomy is. You should have a say. In reality, it's just not feasible that interventionalists look after all these people. And the family physician out there today, in reality, is forced to be closely involved in this. So I say, get the interventionalist to provide guidance. Ideally in their discharge letter, they'll say, this was lots of metal, this is a bifurcation, this is a left main stent, this is a person with stent thrombosis. I think they need 1-3 years lifelong. Or this patient has a very high burden of atherosclerosis, they're at high risk of subsequent events. They need long-term intensification of antithrombotic therapy, but you might consider something other than DAPT. So I think that's really important that the interventionalist provides some guidance there.
I think so, and I'll just say one other thing that
Do you
we
do that in all your notes?
Exactly right. I do very little things anytime, all the time. But let's be clear. Like, I think one other thing I'll just not challenge, but sort of say, I'll call it competing risks. That year after the heart attack, we would all say is the anchor for when you're likely getting dual antiplatelet therapy with 2 of those drugs. From 1 to 3 years, I'm going to call an intermediate time point where the evidence suggests there's some evidence where we're making a decision about extending 2 versus 1. Within that amalgam, there's also other therapies, low-dose oral anticoagulant like rivaroxaban or something like that we could talk about in a second. But that 1 to 3 year period, I think, is still some residual risk from that event with that stent. But what we should be thinking about is that big box of the patient risk that's going to continue on, and that anatomy artery risk that's getting less with time. So I think you're absolutely right that the primary care physician should be getting information from the interventionalist, but they're going to see a lot of patients 3, 5, 8 years out that are on chronic therapy. It's going to be hard to find the note that I appropriately wrote the duration on, let's say 3 years ago. So what you have to do at that point is have this conversation, because a lot of patients, almost every patient I've ever met, they want to de-escalate. They don't like pills. So if I could stop one of these, Dr. Patel, I would love it.
I think, though, John, you are right that the primary care physician has to be part of this conversation, and certainly in the longer-term therapy decision-making. But I also agree with what both of you have said, that the interventionist should write a good note, and I also try to be specific. But of course, circumstances might change. I might say lifelong DAP, but then the person might have a big GI bleed and then another GI bleed. So, you know, it
Develop a
has to
carotid
change.
stenosis, have limb-threatening issues, other things
Absolutely.
that happen.
So stuff happens, for
Yeah.
sure.
They develop AFib and
Yeah, so there's
That's a
hierarchy.
good point,
Right.
yes.